came back to the that.
Yeah, we'll go ahead and get started here this morning. Good morning. My name is Alan Umstead, and on behalf of the You're Not Alone ministry teams, we want to thank everyone for taking time from your busy schedules today to learn more about mental health and, more importantly, families' role of support. Today, we will be learning about child and adolescent mental health, but first, let's pray. Lord Jesus, thank you for bringing us together to once again help us understand the difficulties we are likely to encounter in wrestling with mental illness in the lives of our loved ones and possibly even ourselves. We know you have a unique plan for each one of our lives. Please help us to better understand and better equip ourselves to deal with both pleasant experiences as well as life's difficulties. Please give us the tools, grace, and encouragement to fight this earthly battle and win it. Guide us today in an understanding of your perfect plan for our families. Amen. Briefly, on this program, it is not intended to provide guidance or direction in seeking medical assistance, direction, or medications. Referrals and medical assistance should only be sought from your individual physician or competent expert. At this time, I'd like to introduce to you Amanda Dondero. Amanda is a licensed clinical social worker serving as a child and adolescent outpatient behavioral health supervisor through Winchester Medical Center. She joined Valley Health from Connecticut 2 years ago and has had the privilege of helping design and launch the child and adolescent mental health services that are offered through the outpatient department today. Amanda has worked within residential, hospital, inpatient, and community programs, providing clinical support to children, adolescents, young adults, and families, while also leading successful multidisciplinary teams. She consistently strives to provide inclusive, trauma-informed, person-centered care to those she cares about. Please welcome Amanda.
Thank you, Alan.
You're welcome.
My number one goal is to not trip on these cords. So that's what we're going for right now. Let's see what we do. All right. Hello, everyone. My name is Amanda. I am the supervisor for child adolescent mental health with Valley Health Winchester Medical Center. Like Alan said, I joined the team about 2 years ago to help design and launch our child adolescent services. And I've really enjoyed doing that the past 2 years. We've been able to get 2 programs that I specifically oversee launched, along with our medication management programs. And there's a lot more coming with Winchester Medical Center and Valley Health for outpatient behavioral health that I'll share with you a bit into our slides. So being here in Virginia, the landscape of mental health specifically for children and adolescent services is a little bleak. We have some work to do. So Virginia as a whole for mental health overall has ranked 22nd out of 51 states. Going off of our mental health, and SUD means substance use disorder indicators. This is based off of the data from 2025. That being said, the current data that is out for 2023-2024, the 2025 isn't out yet, is that Virginia ranks 48th out of 50 in the nation for youth mental health, indicating there's a high prevalence of mental health issues in our adolescents and kids and very low access to care. That was a shocking shocking statistic when I read it. It is nowhere where I thought we would be. Part of the issue is that we have 95 counties in Virginia. However, only 4 of them are considered properly staffed to have enough providers, psychiatrists, therapists, and things like that to ultimately meet the needs of the kids that need our assistance. So on an average, there's only 14 providers for every 100,000 children in Virginia. And right now, there's about 14 providers. Actually, I will say that statistic was from last year, but I don't see that gap being much different currently. That ultimately is for mental health specific. If you then try and get a little bit more detailed with where we stand on providers that are willing to provide medication management for patients that are also using any type of substances, is way less. And that also includes nicotine, just nicotine use, or even some marijuana use, which of course we don't want our adolescents utilizing marijuana. However, a lot of the times that marijuana use is some way to self-medicate, and then we have a good amount of providers that do not feel comfortable actually managing medication if an adolescent is using other substances. So just within Valley Health for last year in 2025, 1,414 youth were assessed across Valley Health for safety concerns in 2025. That is our emergency room numbers only. And while we have fantastic emergency rooms within Valley Health that's able to help provide support, unfortunately, there are very limited access to care opportunities for our children and adolescents that are within this state. So Valley Health came in and said, wow, there is a huge need. What can we do about it? And we were very excited to launch some of our services. I'm going to go way more into detail about our services in a bit, but what I first wanted to talk to you all about was the difference. That a lot of times when we're talking to each other now, it seems like mental health and mental illness, the words are interchangeable. And they're not actually. They are 2 separate things. There is some overlap. However, our mental health, all of us have mental health. We can have great mental health, we could have not so great mental health, but mental health is really just the state of psychological and emotional well-being. It can be good, it can be bad, it fluctuates. It is always something to look after. And that being said, if you ignore signs of poor mental health, that can lead to a mental illness. Now, a mental illness isn't something that everybody deals with, although our kids these days, everybody has a mental illness. But mental illness isn't for everybody. It's a set of symptoms which show a problem. Now, a problem is a problem when it starts impacting different areas of your life and you're functioning in those areas. If there is not an impact to the levels of functioning in areas, then it's not actually considered a problem. I guess maybe more of a quirk. Now, our mental illness always has significant impact on how we feel, think, behave, and interact with others. And there can be physical impacts of this. So just think about when you're stressed. Anybody feel something a little specific physically? My stomach hurts when I'm stressed. Our kids do the same exact thing. Now, a new problem that we've run into is anybody here have teenagers or have raised their own kids, have before? We're going to go into this next slide, and this next slide is very specifically about warning signs for mental illness or that your mental health is starting to decline. Now, as we go through all of these, the number one thing that I end up thinking about is, wow, that sounds a lot like a regular teenager. Oh, you mean moody? Difficulty concentrating? Maybe our grades change a little bit. Maybe we're doing things a little risky. We're changing our interests. We're more irritable. Anybody have an irritable teen? Or a teenager that wants to be left alone, isolating in their room, and things like that. As we look at all these different warning signs, what I always hear is, that just sounds like a teenager to me. How do I know when this is more of a problem? How do I know when I need to do something? And this is where you all come in. This is where having relationships and building relationships and open communication with your kids and children and adolescents comes in. Because you are absolutely right. There is a lot of overlap here between just regular moody teen and a mental health, mental illness issue. But the difference is the change in behavior and how quickly it happens. If you know your adolescent, and your adolescent is really into something, and then suddenly, just out of the blue, is not interested anymore, that should spark some conversations. Right. None of these on their own explicitly mean danger. Actually, I will rewind that. A couple of these specifically mean danger. Yeah. So self-harm, substance use, things like that. However, the substance use doesn't necessarily mean that you are suddenly having some mental health issues. Kids do experiment. It's about being able to have the open communication. So the number one thing we tell parents is to notice a difference. If you notice a difference, something is up. It doesn't automatically mean that there is this super high risk, but it means that this should probably spark some type of conversation. And going into that conversation, the most important thing is doing it with curiosity, not with assumptions, not with a tone of, well, this is going to turn into getting in trouble, because I don't know about you, but when I was a kid, if I knew I was walking into something getting in trouble, I'm trying to get out of that. I'm not sticking around for this. I'm not going to be really excited. Oh, yes, here comes the lecture that I was really hoping for today. But it's a conversation. So all of the kids that we work with, ultimately that come to our office, they do have some type of mental health concern. Not all of them have a mental illness, but they do have some concerns. And a majority of the time, parents are able to recognize this by noticing a change in the behavior. Now, multiple of these changes increases your risk, absolutely. Any of these on their own should start raising a bit of a yellow flag at the very least. Of, that's weird. I don't know where that came from, and then sparks conversations. You are not going to ever be able to catch everything. Within our office, we have fantastic professionals that have all the training in the world. However, things are still going to happen. But noticing changes in behaviors and noticing when something is different, when something doesn't feel right, trusting your gut instinct is so important. Yep. And sometimes people feel like, well, I didn't really have much to go off of, it was just a feeling. Feelings can spark conversations. They don't have to spark arguments. They could spark communication. And that is what we stress the most. If you feel like something's up, speak to your adolescent about it, or encourage others to speak to their adolescents about it. Now, don't be going into that conversation assuming that it's going to be like a collaborative, yes, mom or grandpa or grandma or whoever you are, yes, absolutely, this is what's going on. It's going to take some patience with it. But for the most part, and with my experience with crisis work, is a lot of times talking it out really does help. And if talking it out isn't something that you feel like you can navigate on your own, that's where professionals come in, where we have individual and family sessions, where sometimes we do parent-only sessions to talk to parents about, okay, how do we navigate this conversation and things like that. One of the best resources that I always share is actually this website right here, mhascreening.org. If you notice any of these symptoms and you're like, I don't know, should I be concerned here? There are actually surveys online through mhascreening.org, that's Mental Health America, screening.org, that ultimately you can go on this website, fill out a questionnaire, and it will kind of give you some resources. It will tell you, hey, yes, this does seem concerning, this is what you can do about it. And one of the things that you can always do about it is look at the local agencies in the area, which is kind of where our building comes in. And that's a good amount of the focus of kind of the rest. But before I get into the focus, I do usually like to open up for quick questions or anything at this spot, because this usually sparks some stuff. So does anybody have any questions about warning signs? Yes, Alan.
Amanda, for a child, adolescent,
that's in resistance or denial, any suggestions for at least trying to break down some of that barrier to a meaningful discussion?
Yeah, absolutely. So I'm sure those who have been parents recognize that if you say something to your child, it may bounce right off. And compared to if somebody else that doesn't know them or a friend or something like that can have that conversation. So utilize your community when you can. And if that does not work, that's where trying to look at a neutral individual, which is where we kind of see as therapists and things like that, that can come in and help those conversations. We have parents bring kids into our location all the time that are saying, I want you to talk to Johnny about this. If Johnny doesn't want to talk about that, we're gonna try. But Johnny may need to figure out that, oh, I could trust this place and they're going to respect that I don't want to talk about certain things before Johnny agrees to start talking about those things. So it's also recognizing that while you may be ready to talk about it and you're like, this is a concern and it's an understandable concern, that does not mean that the adolescent is on your timeline, unfortunately.
As you said, I think I heard you correctly, this kind of work takes patience.
Patience, yes.
Oh my God.
Very much so. So much patience. And know what our teenagers don't have a lot of? That would be patience. And you know what's really hard to keep up when you have a teenager is your own patience.
That's right.
So a lot of the time we also work with families where we encourage the parents to also get their own supports. The reality is this can be really frustrating. You can have the best intentions in the world, but that does not mean that Johnny is on board with it.
It can be so stressful for the whole system.
For everybody, the whole system. Yes. And I'm so glad you said that, Fred, because one of the things that we do within outpatient behavioral health is we do family sessions. Now, every once in a while, we do get some families that say, okay, this is Johnny. Johnny has these issues. You fix Johnny. Like, go ahead. We need you to fix this issue. And we're going, Johnny's 6. Anything Johnny does requires Johnny's parents to be involved in this, or a guardian, because we can do so much work with Johnny, but Johnny's 6. And most likely, there's something going on with the family dynamic that is contributing to the issue that's happening with Johnny. So we talk to the whole family. We do not have families, sometimes some families might prefer this, but we do not talk to families where we're dropping off our kid and you talk to them for an hour and then we take them back and we go on.
And you just rely on play therapy.
Yeah, that's great.
With the family not included.
Exactly. So we want to include the family. Now, there are some times where we work with the adolescent individually without the parents first. So there are times that happens where sometimes Johnny might need some individual work before Johnny can even tolerate the family work. Or the family might need some work outside of Johnny before bringing them all together can become helpful. Now, that's something to discuss with your treatment provider and your treatment team. Those are conversations to have. You can absolutely advocate. I encourage you to advocate. If you don't advocate, then ultimately you're trusting the professionals, which is great, but the professionals want you involved.
I just want to give you some kudos. People who do the work you do, you really earn your money.
We try.
You're well paid.
Well, just like everybody else, we put on our bootstraps and everything, but we have some of our good wins and everything. Some days are harder than others.
But you work hard.
We try. And a good amount of this stuff, though, that comes with it is ultimately based off of the need. So Valley Health, off of the need. So Valley Health Outpatient Behavioral Health did not have child adolescent services for quite a while. We also did not have, and I'll share with you in a little bit, we have a new building opening up. And part of the reason our new building is opening up is that community members year after year after year, in taking the community needs assessment that is provided for the town, said mental health is our #1 concern. Year after year after year, it was, we don't have access to care. So Valley Health said, all right, let's do this. Let's figure this out.
When one of my 2 sons he's 25 now, when he was 15, he was suicidally depressed. There was nothing here. We drove 3 hours
Yes.
away to a family counseling session that lasted 15 minutes.
Ooh, yeah. Yep, that's one of those barriers right there. So we ultimately opened up these. We currently have patients driving an hour from West Virginia to come to our services easily. When I launched our original outpatient program for therapy, I remember speaking to families that said, wait, you can get us in next week? Yeah, I could get you in next week. We just opened. We have all these openings. Ma'am, I've been waiting over a year on a wait list in West Virginia, an hour away from here, to where it's looking for services of I need help. And we get calls from families all the time saying, I need help. My spidey senses are going off. There's some warning signs. What are these about? These feel really uncomfortable for anybody. Also, these feel uncomfortable for professionals too. I think that's one thing that's really important. We're not uncomfortable with this. We just understand it in a different way and understand, okay, what can we do about it? And that's where I think maybe more of our direction goes a lot of the time. Now, one thing I didn't discuss, and I do always want to bring this up, is the section about self-harm. I want to point out that self-harm does not necessarily mean suicidal. There is sometimes some overlap, but it does not necessarily mean that that is where the adolescent's head is going. Self-harm a lot of the time is what we consider a maladaptive coping skill. It's, I'm finding a way to cope with my feelings in a not healthy way. It technically works for me, it's just not positive. There is some type of relief, there's something that's happening, there's a need that's being met, and it's temporary. But then there's all this extra stuff that follows with it. So that's why I like to point that out when it comes to self-harm, just because it's a gray area a lot of the time.
Yeah, I don't work with adolescents anymore, and I don't so many years ago. Is there something about, like, let's take cutting. Mm-hmm. Is there something that happens physiologically?
Absolutely. There's a rush of endorphins, there's a rush of hormones, and everything. It's the same as if there's an adrenaline rush that comes with it.
As if they went for a good jog.
Yeah, it's a super stimulating way to manage a behavior.
Yeah.
Yet again, it's not that we ever want our kids to do this.
Like you said,
However,
maladaptive.
it's maladaptive. It meets some type of need. And what we do when we work with patients that utilize self-harm is we go, okay, can we replace this behavior with something healthier?
Yeah.
Now that might be, I need to replace it with 5 positive things to equal the rush that I got from this one negative thing. But if that's what needs to happen, that's what needs to happen. So as we go through, what I'm going to be discussing kind of forward is actually the services that we have with outpatient behavioral health. I'm trying to focus just on the child adolescent services. However, there are a bunch of resources I left in the back of the room that also has our adult services on there as well that I think is just important to know, because we serve ages 5 through 99 plus, whichever it is. So it's little writing, we don't have to spend too much time. But this is basically just the timeline of outpatient behavioral health through Valley Health. So we actually started with Shenandoah Memorial Hospital, just that location, and now we have Shenandoah Memorial plus our 2 locations in Winchester. We also used to just serve adults. However, in the past few years, we started serving children and adolescents. So this cute little building. This is our outpatient behavioral health child adolescent building. It's quaint, it's cozy, it's cute. Huh? So we offer a lot of different services. So ages 5 to 17, we do psych evals, not the extensive neuropsych testing. So there's differences. There's testing, which is usually several days long. It's really in depth. And then there's a generic evaluation. We will do the generic evaluations along with medication management at our location. We have 2 board certified child adolescent psychiatrists. We have Dr. Borkon and Dr. Demina. They are absolutely fantastic. They both see our mental health patients for medication management. In addition, we have our mental health outpatient program. This is for ages 5 to 17. It's also a program I oversee. I have 2 male clinicians. I say it proudly because if you know much about this field, finding male clinicians is really hard. And I got 2 of them. Wow. I know. I got really lucky, honestly. Right? Let's figure this out. So we have 2 fantastic clinicians that see patients. Caseload size is right now about 40 patients for each of our clinicians. We are on a bit of a wait list. 40. Yes. Actually, technically, my clinicians fluctuate between 40 and 45 patients at a time usually. So we currently have, I just did the census yesterday. I believe I have 82 patients in my regular outpatient mental health program.
So this is where they meet?
Yes, this is a little building.
Where is it, West Side Station Drive?
Yes, West Side Station Drive. So if you know much about Winchester Medical Center, the big hospital campus, we are not on that campus right now.
Across the street.
We're across the street behind the McDonald's. I know, it's great for the kids, not good for my diet. There's a lot of things. So, along with our mental health programs, we also have substance use disorder outpatient. So we have a fantabulous team that works with adolescents that are utilizing substances. It's for ages 12 to 17. It has individual family therapy, group therapy, medication management, some peer recovery services, and that's ultimately in order to support the patients and their families. Our substance use disorder program is for Winchester City adolescents, for Clark County adolescents, and Frederick County adolescents. It is actually funded through a grant and has had amazing outcomes with reducing our adolescent substance use. Something else we have, all of our care is physician driven since we're part of a hospital system. So everything basically goes through our psychiatrist, our providers. We have peer recovery support groups, our school-based psychiatric services, that is part of our substance use programming, where our staff actually go into the schools and will meet with the adolescents that are struggling with substance use in order to try and continue to engage with them. And then we have our mental health adolescent intensive outpatient program. So not only do I supervise for these programs, I'm also the therapist for the IOP program. Our mental health IOP program serves adolescents ages 12 to 17 that are either stepping down from an inpatient hospitalization or are stepping up from no services or lower level services that require some more intensive care. Ultimately, my IOP program is 3 days a week. It is Monday, Tuesday, Thursday, and we do a lot of group therapy. I also just realized, we do a lot of group therapy together. Average stay is probably 6 to 10 weeks, and all of the patients that are in my program have some type of safety concern, whether that's suicidality, self-harm, wanting to harm others. And we are strictly mental health. Our patients are not also dealing with substance use disorder issues. That is ultimately referred out to a different program. And then we have our RRWP program, which I just realized I skipped the next slides because I started talking. I know, happens all the time. So ultimately, I shared most of this already. Our substance use disorder program, we screen for substance use risk. We check for mental health symptoms and trauma history. Low, moderate, or high risk, we determine the risk level. Services include individual family therapy, individual peer recovery services, a weekly youth recovery group, and case management services. It's also driven by physician care. We have case management, and what everybody loves is almost all insurances are accepted.
Amanda, what is individual peer recovery?
Great question. So we happen to have a couple of staff members within our team that are considered peer recovery specialists. These are individuals who have been there, done that. So these are individuals that we have one through our peer recovery program, Nicole. Nicole is somebody that has lived through addiction. She has lived through addiction.
Like a former alcoholic.
Yes. Absolutely. Lived through addiction, did her own recovery, has been in recovery for quite a long time, and ultimately pursued further certification to be able to gain this peer recovery specialist title. Now, peer recovery specialists are able to work with the youth and the adolescents in a one-to-one or group basis and can relate to them. Can say, wow, you're struggling with alcohol. I remember when that happened to me. And this is what I did. Or this is the treatment they tried to have me do that I didn't think was helpful. But now that I'm looking back, I'm like, oh, this is what they were talking about. So it's a staff member that's able to relate to the kids and kind of just speak to them more casually and make those connections. Because as I'm sure you all know, and kind of going back to your question before, with those warning signs, what do I do if I can't get my adolescent to talk to me about it? Well, you could get someone that's been there, done that, and see if we can have some conversation. So a lot of our patients in our substance use program, honestly, I kind of like to joke that our staff work on kind of cracking that harder outer shell of like defense through our peer recovery specialist. She is fantastic. If you ever meet her, you will know it's her because she is quite loud and energetic, and the kids act like they hate it, but they love it. They absolutely do. She gets a lot of eye rolls, but we know they enjoy it. And then we also do our urine drug screens. We do our urine drug screens within this program as well. Our RRWP program, this is a brand new program, probably started 1 to 2 months ago. So this was ultimately, remember how I was saying before that we sometimes have a hard time with getting providers who are willing to prescribe medications if a patient is using substances? Well, Valley Health was also one of those providers. Our providers said, wait, what else are they going to get? Just medication isn't going to fix and help support the patient and the family through this problem. So we need more instead of just medication. And that's where our RRWP program came in. That peer recovery specialist I was talking about, she gets to run this. She's fantastic. It's an 8-week program. It's about 2 days a week. The youth and their caregiver has to participate. No caregiver participation, no pass go. We are covered by insurance. It is usually, this program is mostly for smoking cessation, early intervention specifically for nicotine and cannabis use. We're not talking about the harder drugs. They are not going to meet criteria for this program. This is considered a lower level risk program to then build up to refer to other resources as needed. They receive all these different things within the program though. We have our individual and caregiver stuff, group sessions, case management, caregiver support, care coordination, harm reduction. Harm reduction ultimately means we can tell somebody that's using substances every day, don't do that. We could say that. But the likelihood of just cold turkey of, okay, well, you said don't do it, so now I'm just not gonna do it, is not really there. We focus on harm reduction. This is, can we reduce the amount? Can we reduce the harm that it's causing? Now, eventually, we're hoping to get to don't use it all, realistically. But going from I'm using every day to you want me to use not at all is probably not going to set someone up for success. So we do harm reduction, which is if you're using every day, can you go a day without using? Or if you're using this substance, could you use a less risky substance? And it's about trying to reduce the risk step by step until it's not an issue any further. It is not encouraging use whatsoever, but we're trying to set up the patients for success.
You're weaning them.
Yes, weaning them. That's a perfect way to put it. I spoke about my IOP program because I skipped the slides. Ultimately, my IOP program, we generally, we do family sessions, we do group work, we do individual sessions, we do treatment planning, and we do discharge planning. My program, you don't leave unless you have a plan after, for some aftercare plan. An individual therapist and a medication management provider usually. At the very least, when you discharge, you are at least going to have a list of places that can be an option for you. Most of the time though, I want you to leave my program with a confirmed appointment for your next step. Every once in a while that doesn't get to happen, but we get as close as we can to it. Now, I alluded to this before. We have some exciting stuff coming soon within Valley Health. Currently, we have 2 small, and when I say small, I mean small, space offices that are in 2 separate locations, less than a mile away from the hospital campus. We have our adult program in one location and our child adolescent in a different location. In October of 2026, we actually have a brand new building opening for us. Valley Health over the years has heard from the community needs assessment, we need mental health support. It's the #1 thing every year. So Valley Health decided we're going to build a building for this. So currently, if you go onto Winchester Medical Center's campus, you're gonna see 2 buildings under construction. One of them is ours. We're really excited for it. Yes, we're really excited for it. We got to go in with our hard hats and our vests about a month ago. I know, it was nice. And I was standing in the lobby and I was looking down the front area of the lobby and I started laughing. And my director said, "What are you laughing about?" And I said, "Just the size of this lobby, it's as big as our 2 buildings we have now combined." And she looked and she goes, "You're not wrong, it is." So this building is about 3 times the size of our current buildings. And there is some discussion, or at least I think long-term plans, that there can be expansion at some point if we're getting the services. This all comes from ultimately the community saying, we need help. Please, somebody, we need a place to go to. So speaking of, that is going to be our brand new building. It's hard to see in the photo, but this little words here says hope and healing for mental health. Valley Health actually made this building specifically the face of the fundraising campaign 2 years ago when I came into Valley Health. And we have been able to raise, I think, almost all of the fundings for this. From donors, from charity events, from fundraisers, things like that. And this really is supposed to be a center for hope and healing. Wow. The left, or if you're looking at it, this side of the building is going to be for adults. That's the adult entrance. Okay. The opposite side is for child adolescents. So this little vestibule area has a divide in the middle. Child adolescents go through one side, adults go through the other, and then you basically have the front lobbies are separated. So we're keeping our child adolescents in their own side and adults in their other side. And then in the back, behind the front desk and everything, it is open and everything, but we're basically keeping the building split in order to just serve the different populations. Speaking of the lobby, this is one of our lobby. Speaking of our group room, I'm really excited about the group room. My group room currently is so small I can't fit a table in my room. So I have 10 patients in my group and I can't fit a table because we're already busting at the seams. This is gonna be the new group room and I could picture the table. It's gonna go right there. It's gonna be so good.
Someone's excited.
Oh, I can't wait. I can't wait. And I'm sure the kids are as well, because I don't know about you, but none of my teenagers in my program sit still. So when you don't have a lot of space and having a hard time sitting still, it gets difficult. So for any of our services, we have a pretty simple referral process. 1, call. Easy enough. That's the number. We started a brand new intake line. So I want to say maybe less than a year now, or maybe a little bit more than a year. We opened up an intake line. So previously, you called that number, you reached our adult program. Then we started our child adolescent program. You called that number, and you had option 1 and option 2. Option 1, adults. Option 2, kids. But then we started our intake team, and our intake team fields all the referrals. So you, a family member, anybody that has concerns can place a referral. Now, all of our services are voluntary, so that's important just to know. However, I can say some of our substance use programming does have some court orders that are within it, but for the most part, we're pretty voluntary. So do not place a referral for someone that's not willing to do the services. But we'll call them anyway and see what we can do. But if you or you know somebody that is looking for services, whether that is our child adolescent services that we went over, or even our adult services, I will super quickly plug our adult services, just like we have for an IOP for our adolescents. We have a very well and long established IOP for adults. We also have a baby IOP for seniors. So that's another program that we have that can meet 1 to 3 days a week. It really depends on the senior and what their needs are and their ability to be able to sit in a group for that long. But it's also another program. We have regular outpatient, regular medication management. We have regular therapy for the adult programs as well, along with not specifically the smoking cessation program, but there is also individual peer recovery services that have recently been launched for adults.
Up till now, there hasn't been services for older seniors?
So we actually, that really long timeline I had, Valley Health actually started off with that senior program a while ago. So where are we? Right here, 2013. We started offering ages 55 up.
All right.
Then we did it again.
Yeah.
And then we just expanded to outside of just seniors. So we actually started off with the senior population.
Awesome.
If anybody knows our director, Diane Ritchie, she is fantastic. She is Wonder Woman in my eyes, because Diane was the only staff right here. And she has built all of this. I mean, granted, Diane is super humble and she's gonna tell you, no, my fantastic team did all of this, but Diane brought us all together and has been such a big part of making all of this happen and expanding that she deserves her own shout out for sure. And when I say she would absolutely say, no, it's you guys, that is absolutely the type of person she is. So for any referrals, whether it is for child, adolescent, adults, seniors, call that number, hit option 1. You will either get somebody on the phone from our intake department, or if they are on the phone already, you leave a voicemail and they will call you back. They will do a pre-screen intake, which is ultimately, these are the services we have, what are you looking for? They're gaining some information and everything, and then it's a discussion. Whether we have the services available in the moment, if there's wait lists, what it looks like, and then you can get scheduled. The pre-screen is done to determine clinical necessity and level of care needs. If you talk to the pre-screen person and they say, you give them information and they go, oh, I don't know if we have any programs that meet that, they will let you know. We're also pretty big on, if we can't do the service, we're gonna try and share a resource with you of a place that can. So every once in a while, there's some weird nuance, we call it a unicorn, of like, I need a male therapist that specializes in OCD while also dealing with some gender question issues. Well, that might be a little hard to find somebody that fits that exact box, but we're gonna try and get as close as possible. As long as a patient meets the necessity for our programs, then we're gonna move them along to getting them scheduled. We have some things that are changing within Valley Health Outpatient Behavioral Health as far as processes, so more to come. Currently, every patient needs to see our psychiatrist, since we're part of a hospital, for all of our programs. Psychiatrist needs to admit them, then a psychiatrist orders the program. We have some things actually coming in the near future where we may be able to offer therapy-only services instead of services that have to be connected to medication management. So there's more to come. I said that already. These are just, so like I said, I oversee the IOP program. Every time a patient discharges from our program, or technically any of our child adolescent programs, we give them a little testimony. And it says what this program has meant to me. And we ask them to write it down. And this is just some of the stuff that our adolescents have said between all of our different programs. And the next slide is just one that says Q&A, but I like to leave this one up because it feels good. So I'd like to open things up for questions. Yes, Alan.
Amanda, what you're doing is great and fantastic. To me, there's a large group that say is 18 to 25 that is transitioning from parental control to self-control. High school seniors, college students.
Yes.
That to throw them into the adult category to me seems like a stretch, and not as a negative thought, but are you planning on doing anything with what I would consider them, they call them young adults, let's say under 30 or 25, or pick an age, because that group to me, you want to stop them from deteriorating mental health wise further. And so what kinds of things do you do now or in the future with that age group, 18 to let's say 25?
Yeah, absolutely. So currently we don't have any young adult specific treatment within outpatient behavioral health. And what I mean by that is that there are some programs, not really around here unfortunately, that has specifically this is for just young adults. Now we don't have that within outpatient behavioral health. What we do have is my fantastic male clinicians, as they have patients that are quote unquote aging out, so they're about to turn 18. 3 months before their birthday, we start working on, okay, what's gonna happen after they're done with us? Because our cute little quaint building, we do have rules that basically, for the most part, when you turn 18, unless we can basically apply for, it's called a variance with the state, once you turn 18, you cannot be served in our building anymore. You have to be served in our adult building. That being said, I just had this happen. I had an adolescent in my IOP program that turned 18 in my IOP program. Was she ready to discharge? No. 2-3 weeks before she was scheduled to discharge, AKA her birthday, we put in an application with the state. And the state has a rule that ultimately says you can't have adults in the same program as kids. Well, once you're 18, you're considered an adult. So we had to apply to the state to say, this patient, yes, is turning 18. However, it doesn't make sense for her to go with the adults. She's still in school. She's not going to be able to meet the adult program times. She's getting along well with the other teens in the program. She's appropriate with the other teens in the program. Can we get an extension? This is why we need it. And the state said, yes, absolutely. Keep her. If that makes the most sense for her treatment. So we were able to work with her for the rest of her programming. So we're able to do some things with some of those transitions. One of the things that I get to do with Valley Health is actually go to different conferences. And one of the things that I have been noticing, I was just out in Harrisonburg a couple weeks ago. And one of the things I noticed at the conference was there seems to be a lot of different programs starting to open specifically for transitional youth. So young adults that are transitioning out of adolescence into their adulthood. Now, I don't know of any of those programs out here, unfortunately, though. And I think that that's something that, just like Valley Health got survey after survey of this is what we need, the more Valley Health and other agencies see the transition age being a need, I think the more people will come and reach the challenge. I'm actually really happy you talked about that population, Alan, because that actually is kind of my favorite population. I did that previously, working with young adults. It was my favorite. It was quite difficult, but it was a good time because we got to work on being able to teach these adolescents turning into adults how to be independent. And that was really exciting to be able to be a part of.
So is it more legislative related, in other words, the law of the state of Virginia, or is it not having enough facilities to cover another, if you will, age group?
So Virginia doesn't say don't have young adult services and things like that. It's more so of, just like with anything, the more there is a spoken need of it, the more people pay attention to it. And what actually tends to happen, I'm not from Virginia, I'm from Connecticut. Connecticut actually did very specifically have a young adult services program for kids aging out of state custody and things like that. And then it morphed to not just state custody kids, it just morphed to teenagers, young adults in general, because people kept asking for it. So I love hearing interest in this stuff, because interest means that you can kind of start spinning the wheel and getting attention for it. So if there are different programs or different things that you're seeing, man, there's a hole there, speak up about it. Make it known, because the more you speak up about it, the more people will hear you. And our pavilion is a perfect example of that. For years, the community was saying mental health #1. And years, the community was saying, well, we keep saying it, what are you doing about it? And Valley Health realistically said, all right, if they're saying they need this consistently, we're gonna figure it out. Your legislators, your community members, realistically, like any different type of policy, if the people it affects are speaking up and coming together to highlight it, the people that need to hear it are eventually going to hear it. And that's why I was really excited then Alan reached out about coming and talking to you guys, and that different members from my program and department have been here to speak for other reasons. It's all about just speaking up. We want to get the word out about what we offer. It's kind of funny, we've been doing at least, let's say, just the child adolescent therapy, the regular therapy. We've been doing that for about 2 years now. Still to this day, in our hospital, our Valley Health Hospital, I hear from staff all the time, wait, you have child therapy? What? Yeah, we've been doing it for 2 years now. Oh, I didn't know, I thought you just had adult services. So even within our own kind of agency, it's hard to get information out, let alone partnering with other agencies in the community. And that's actually a big part of what I do is, and what a lot of people within our management department do, is we work on making connections.
That's puzzling. I mean, you would think the word would spread like wildfire.
You would, absolutely.
Because the need is so great.
However, also at the same time, if you don't need the need in that exact moment, you might not register it's there. People don't realize what is or isn't there until you go looking for it, until you need it. And then all of a sudden it's, wait, what? You do have it? Absolutely, come on through.
Are there going to be, in this new facility, psychiatrists for the children and
Yes.
psychiatrists for the adults?
Yes.
And are they going to be there, or are they coming from somewhere else?
Great question. So my understanding is we're going to have a mix. We have people that are going to be stationed there full time. We have some people that are going to be doing in-person and telehealth options, so that it can be reached. We also have, and I didn't put it in our slide, but there is a fantastic initiative that, and through a grant that we got awarded, we're actually putting therapists in our primary care doctor offices now. So there are, I think, 6 approved primary care doctor offices that we are in. I want to say 4 or 5 of them right now, with the 6th coming up very shortly, where we ultimately are able to connect patients to a therapist right from their primary care doctor appointment. And that does not mean it's always in person. We do use virtual quite a lot for this, because the 6 offices are across multiple different counties. So it's not just like, oh, 6 offices in Winchester. It's no, we're in Warren County and Woodstock and Winchester. We're kind of all over. So that's also a program that's continuing to expand, to continue to improve access to care. Because that seems to be one of the biggest things, whether it is we don't have enough providers, whether it is we just don't have enough places or options, or whether it's we have options, just we don't know about them because we don't talk to each other as much. That's one of the things I'm really passionate about. And Alan and I have kind of spoken about how a lot of the times an adjustment I've had to kind of come to within Virginia is that a lot of the services are very siloed. It's we do this here and this is for us. And then we do this here and this is for us. Even if we're doing very similar things, why can't we work together? And we've been working really hard on that, and that's why we love these opportunities to come out and present to nonprofits, to conferences, to all these different things so that we can get the information out there, because I didn't even know about you guys. And then I found out about you guys and I was like, why doesn't everyone know about this? We work so hard to work on building new conferences and things like that when we have community members already pulling together to talk about these things. And the more you guys can talk about it to others, the more you can invite people to come to these, the more that you are able to engage, or us, that we're able to engage with the community that we're serving, the more we're gonna have a pulse on what's needed. And we're gonna be able to get feedback. So keep advocating, keep speaking up, always make sure if you have questions, ask them. What's the worst that can happen of asking a question? If you are not sure that MHA, I should probably just go back to it so I don't get it wrong. The MHAscreening.org, they have different screenings on this and a bunch of different resources. If you're not the most tech savvy and you're concerned, call our office. We'll talk it out and everything. We're going to work on figuring it out, and if we can't figure it out with you, we're gonna try and point you in the direction of who can, while also just recognizing that we're all basically in this together, and we're all working on trying to figure out how can we help our youth. I'm saying mostly youth because I'm the youth person here, but for any individual that needs some assistance.
And it's heartbreaking how much the youth are suffering.
Very much so. I think COVID-19 was a big impact on all of us. It did not help our youth.
But we live in such stressful.
We live in very, very stressful times, which is why paying attention is so important. If your kid comes home moody one day and they're isolating, that doesn't mean now we have a mental health crisis. It could just mean we're having a bad day. But if there's a pattern of it, noticing that pattern is what's going to be really important to then spark conversations.
Amanda, does your experience in the field match up pretty much with what they're saying are the rising suicide rates of this age group?
Yeah, so there definitely is rising suicide rates. It definitely fluctuates at times, but yeah. Personally, what I've noticed with impacts of COVID-19, I run the IOP program, which is heavily group-based. Groups before COVID versus groups now, kids have a lot harder time communicating to each other now. Just to have a conversation, to share something vulnerable, the idea of doing that in front of another adolescent now seems even more of like a hill to climb. And
that's exactly what they need.
Yes, it is exactly what they need. So half the time in group, the flow of group has definitely changed. And we try and work on it as best as we can, but just like the pandemic impacted all of us, the way it impacted the kids was through isolation. And yes, COVID isolated all of us, but just think about what development you're supposed to have as a teenager.
Years of socializing.
They missed years of that social development, and now we are dealing with it.
Right.
We have kids that struggle with dealing with any type of frustration in general. We have definitely, as a society, kind of encouraged our kids with more instant gratification with electronics and things like that, and then we get confused why their attention span is 30 seconds long. And it's like, well, the videos they're watching are only 30 seconds long, and then it just moves to the next stimulating video, and then the next stimulating thing. It's really hard to it's really hard to compete with. And that rewiring the brain, that's something that ultimately we can use to make the connections with the kids. The kids know about rewiring with electronics. Our brain does the same rewiring. We're working on going down the same pathways as much as we can to try and build new behaviors, new skills. And when an adolescent is struggling with something, it's because they're struggling with the skill it takes to do the activity or to do the behavior or whatever it is. And it's really important for us to remember as a whole that if somebody isn't able to do something, specifically an adolescent, it's probably because they don't have the tools to do the skill we're asking them to do. So modeling behaviors is super important. The kids seem to like that there's an activity I do with a lot of the kids and their families, call it the redo skill. My favorite, because a kid can call a redo on their parent and a parent can call a redo on their kid. And that means if I say something that comes out wrong, call a redo on me and I'm gonna redo this. Now I could just say, parents, you could do that to your kid, but that's not modeling any behavior. That's parents going, ha, gotcha, redo. But if I can get the kid to be able to do that to the parent, because I don't know about you, my dad loves sarcasm, and sometimes it doesn't hit great. But I can call a redo on him. If he says something, I go, redo. And he's like,
Gotta redo that.
that wasn't okay. And he has to think about a different way to say what he wanted to say. Him modeling that is the 100% thing that any child needs, is to model behaviors. So our parents within our program, they don't get off scot-free because they're part of the solution.
Yeah.
And everybody as a whole is a part of the solution. Yes.
Yeah, so I want to tell you a short story. I'm a recently retired family physician who had a special interest in mental health care, and I've written on depression and anxiety. But I wanted to tell you that Valley Health is a little behind 2 hospitals in rural Kenya, where
Oh, wow.
in one of the hospitals 7 years ago, we introduced this, including going out to the schools. And 2 years after that, another one. So Valley Health is kind of catching up with rural Kenya. And if,
Wow. Wow.
and if they'd like some support, I'm happy to introduce you to the people who have made this happen.
Yeah, absolutely. I think of the silos that I was talking about before. Valley Health is really working on breaking those down. So previously, at least the local schools did not like people coming in at all. It's like, this is a great service, that's fantastic, our students could really use it. However, no. Because, for all different reasons. Some speculating here, is we've definitely heard of, at least one of the local school districts have said, we don't want you doing therapy during the school day, unzipping a patient, they called it, and then sending them back to class. Okay, there's something to be said about that. However, over the past several years, our programs have worked really hard with the local schools to work on being more collaborative of, can we come out there? Can we do this? And schools are starting to allow this now. So we're breaking down those silos to really work on helping to make the connections, to continue connecting to nonprofits like you all, to connect to the schools. I said before that our substance use program was Winchester City, Frederick County, and Clark County. It just got announced to me 2 days ago that we finally got the approval from Clark County. Clark County was not part of our services whatsoever. It's been years in the making. Yes?
Well, I assume you get parental permission.
Yes.
When you go into the school, but work in a public school, and I could see one factor that is a barrier, state standards about how much time students need to be engaged in academics.
Yes.
And that stresses everybody.
Mm-hmm.
You know, it stresses the adults, it stresses the children, and you're finding the time for a service like your service, or even a time for the children to engage with one another. It's the way the standards are. It's very different.
Definitely. I mean, so many people are just trying to meet the regulations, and sometimes the regulations leave very little wiggle room to be able to actually potentially add more services or add more supports to be able to help out. And I think that's where continued conversation comes up, of members of the districts advocating for, this is what we want. We are really excited. I believe Alan and his wife, came to a conference that was just held recently from the Northern Shenandoah Valley Alliance. where we had a speaker. There's this documentary called My Ascension. A long story short, it is based off of a teenager who did attempt to take her life. And she attempted to take her life, and very luckily she survived. She is in a wheelchair now, partially paralyzed. However, she did this whole documentary about, this is what it felt like. This is where I was coming from. This is what I was thinking. And the moment, she literally says, the moment I pulled the trigger, I was like, I don't want this. The moment. And it is her reascension back to being functioning of her own PT, of she spends her time now traveling the country, doing these talks. Now, we were really excited for the conference we just had that she actually was able to virtually participate and speak to our group. We are very excited that our pavilion opening is that Emma Benoit is her name. She will also be present, well, at least virtually present. And we are also working with the Frederick County School District and Winchester. There is very likely going to be a public screening of the documentary and a panel discussion that we are looking to do. There's some details to be kind of smoothed out, but that will be announced for community members to be able to. I believe we're actually, one of the local schools is looking to open their school to show this documentary to anybody in the public. So it will be an open community event that we'll be advertising.
So the only place we could view it would be in a movie theater?
So we have a couple different ways. So one, there is a local school that may be showing it at their school, like an after school hour event. And then not so much a movie theater. But the documentary can also be found online if anybody's interested. It's called My Ascension. You may need some tissues. It's a bit of a rough documentary in a couple spots. It's raw. The documentary starts off with the mom's 911 call, and it's rough.
Have you reached out to the school nurses?
Yes, so we've been talking to the school nurses, the counseling departments, and the guidance departments and everything. So we have all those contacts. We're really excited with the different partnerships of the different schools in the Winchester area. Sharando has their Out of the Darkness walk, usually every September, October. It's a suicide prevention walk. We usually have a table there where we just give out resources, kind of discuss. The more that we can get involved with the community, the more the community is going to want to get involved with us. That's how I feel very strongly about that. So.
Amanda, you had said earlier that mental health is probably one of the highest priorities for our community. What do you see in your capacity are the choke points to improving treatment, help for the community? Is it more brick and mortar, more buildings? Is it more counselors and psychiatrists? And,
all the above.
And I know that, but is there one that's more a choke point than others? I realize it's all the above, but where should more emphasis be placed?
I think it's really important to recognize how what's going on with the government impacts mental health services. Valley Health, I believe, I feel like I'm close on this statistic, but don't 100% quote me on it. I believe about 70% of our patients are Medicaid. And with all of the Medicaid cuts that have just kind of trickled down, there is a lot of adjustments that we're looking at currently of not to cut programs, but how do we shave off stuff to be more efficient? And how do we meet the bare minimum requirements while also providing great care? So funding is a big issue. In the medical field, you'll probably hear mental health is usually not the moneymaker. It's just not. It's not where businesses thrive. It is where businesses open things because the community say they need it. So getting the word out, I think, is a big barrier that we've been slowly working on, and we love these opportunities to come on out. So the more we can get the word out, the more we can continue to listen to the community about what programs are needed is just as important. And then ultimately, I think we have the patients that need the services. If we're able to continue to show that we have all these needs, that I have a wait list currently for my therapy program. I want that wait list, in part, I don't want it to be crazy long because that means I have kids that are in need, that are just sitting there. But if my wait list is big enough, I also get to prove that I need another clinician to get the funding for another clinician. So it's very much so about how all these different systems work together and how they impact each other and how it changes from week to week or every 4 years or whichever it is that then impact, and then we ultimately need to kind of figure it out. I personally feel like the biggest barrier that I face currently is the communication across agencies and things like that. It's not that agencies aren't talking to each other, it's that agencies are working on focusing on what their agency does. And nobody can fault them for that. We focus on what we do. However, we're also here for patient care and how can we work together to just make it easier on all of us. Some of the stuff I might have talked about today, you may have had no idea we even have. And we've had them for at least a good amount of it for 2 years. So I want the ability for information to go to the community quicker. I would love that because the quicker the word's out there, the quicker that we can help. Yeah.
Yeah, I think I know the answer to my own question, but I'm gonna ask it anyway. Do you try to spread the word? That last count, I heard there's about 150 churches around here. Do you do any outreach to them to let them know about your services?
So we have different ways of outreaching. I'm glad you actually mentioned that because there's a project going on that I am leading that we send out these outreach mailers to share with the community about this is what we have. Now, previously, I sent those mailers to primary care doctor offices, any of the mental health or substance use agencies, and that was probably my first round. Very recently, I added pediatricians, and I started adding churches to that. So ultimately, and actually, I have to shout out that you guys actually inspired that. You guys are a nonprofit connected to a church and everything. And when I was originally talking to Alan, I let him know, man, I work really hard to partner with the inpatient units. Like, I really have been putting a lot of effort into like, hey, let's smooth this out. And for some reason, we keep hitting hiccups. And then I started talking to Alan and I said, I don't think those hiccups would probably happen if the community was behind it too. So realistically, this opportunity has kind of made a shift in a bit of my thinking as far as being able to reach out to the community of there has to be other churches aside from just this one that care about this topic, that want to hear about it, that want to know more. So I have started adding them onto my mailer list, and my next big mailer will be going out to churches as well.
I just want to give you kudos because your whole presentation, you obviously love what you do. You have enthusiasm about it. You have experience. You have knowledge. Thank God that you do what you do.
I appreciate it. Thank you. In the back, I know you all have your own resources, but I did add resources. There's flyers for our different programs. There's flyers, there's a front and back of all of our programs. And then there also are resources for 988. If you haven't heard of 988, that is the suicide crisis line. And there are, in the back there's stickers for 988. If you happen to see them randomly in random places in the community, I may be encouraging people to randomly place them places. So if you want to grab stickers and do that, that's on you. But also in the back there is a little handout that has suicide warning signs for youth, suicide warning signs for adults, and there is a rip apart that has something called a safety plan. Safety plans are the #1 thing that help in a crisis. I'm a big fan of safety plans for everything. It doesn't have to mean you're suicidal. It could be a safety plan for when I'm really upset. So in the back, feel free to grab any of those to look at it. And all of that I'm actually going to leave for at any time if anyone needs anything. And then that number if I get back to it. That number, if you press option 2 and you ask for Amanda, you reach me. Feel free to give me a call anytime, more than willing to talk things out. Alan also has my email address. You're more than welcome to share that with any members. Yes?
You see so much in teenagers and things like that, burning and cutting. And it's a lot on you, I'm sure. How do you cope with this stuff? Do you have any programs for people like you? I know we have things for ministers here that see a lot. And they
Yeah, that's a great question. So we actually call that vicarious trauma. So there's a fancy word for it, and it's how other people's trauma can cause trauma in us. We talk a lot about self-care. We talk a lot about our staff satisfaction within Valley Health. So there is our EAP program, which anybody can utilize within our services for extra support. But a lot of us really just work with our supervisors of really stressing how we're going to care for ourselves. So there can be a really heavy day, and we're so close with each other that we're able to actually recognize, like, Susie's off today. Why is Susie off? And we're not going to let Susie be off. We're going to check in on Susie. Now, Susie might say, I'm just having a bad day, I just need some space, no problem. But the next day, how are we doing today, Susie? What are we going to do to, this felt icky. Sometimes some of the stuff we talk about feels really heavy, and I almost relate to it kind of like tars on my skin. Like, oh, just get this off of me right now. I can't sit in this. And all of us have our own things that we've learned through our schooling or through trainings of how do we care for ourselves. The new pavilion, you guys saw how excited I was about the pavilion. I'm a little geeky excited about that pavilion's gonna have a vending machine. My building does not have a vending machine now, but my number one way in previous jobs I used self-care was when I needed a minute, I just went for a walk to the vending machine. I didn't buy anything, but I'm walking to that vending machine. I just needed a lap. So the vending machine that's going into our office, yeah, I'm gonna buy stuff. But half my trips are just going to be, I just need a minute. I just need a second. The pavilion also is going to have outdoor seating area for staff to take a break. We all have, in all of our offices, you'll probably see some fidget toys. I joke around that my staff and me use it more than our kids and our patients. So we all kind of find our own little ways. And that being said, we also have good relationships with our supervisors. So if my supervisor's meeting with me after something pretty traumatic and I'm like, oh, I'm good, but my supervisor is noticing a change in behavior, just like I was talking about the warning signs for kids, my supervisor's gonna talk to me about it. And I'm gonna talk to my staff about it and be like, hey, this is what we need. So we also really support each other. And if push comes to shove and it's a little bit more than we can handle on our own and in-house, then we reach out to our resources, our own EAPs. Sometimes our staff will go and see their own therapist for a short period of time just to kind of reprocess stuff. If there is an incident or event that happens, there's almost always a big brief with those that are involved in it. So if something happens with a patient and me and somebody else was involved, it's not just going to be it's sticking between the patient and me. The event's going to happen, and then we are going to discuss it as a team so that we all feel supported by it as well, which is very, very helpful at times. And it allows us to kind of process and just support each other. So I think that's what really comes with self-care. And you'll probably, if you heard other people kind of within my position or within the mental health field, they would probably laugh with you saying self-care because people talk to us about self-care all the time. It is probably like one of the top things in conferences of self-care, self-care. There's always something about self-care, and it's really easy to kind of dismiss as, oh, well, yeah, okay, another self-care thing, but they stress it so much because we do need to care for ourselves. We can't help anybody if we're struggling ourselves. So that's kind of where a lot of that comes. Well, thank you all very much for the opportunity. Thank you all for the interest. And absolutely, and if at any time you have any questions, feel free to call or email or pass it along to Alan, and I'm sure he'll get it to me. All right, thank you all.
Thank you, Amanda. Very good.
Just a few things here to close out the meeting. Thank you, Amanda, for sharing information on what Valley Health is doing. We're very grateful you guys have a vision, and not only that you have a vision, but you're actually acting upon it, and that's great. Our next seminar is coming up on June 20th, the third Saturday of the month. We have John Avery, which actually is one of the ministers here at our church. It's going to be more of a biblical look at mental health as far as that goes. And John's been here before, and we're grateful that he will be here and be our speaker then for that meeting. We have support group meetings this next month in June. We're looking at possibly changing it to the second and third Thursdays of the month because a number of people will be on vacation, and Helen will be sending out some information on those meetings. Website, again, we do have a website for those of you that are looking for more information. It's just simply you'renotaloneministry.org, and we have a calendar there with some information, and a few of you have asked for some additional information, which we'll get out. There's a resource table in the back to help yourself. There's a lot of good things there, and Amanda, we thank you for bringing us some additional ones. Now, let's just close in prayer. Lord Jesus, thank you for our time together this morning to help us as families, to lean on you for your strength and power through prayer. Always strengthen our resolve to love and understand those of our family who are afflicted with mental illness. Help us to avoid frustration, judgment, and isolation in our lives. Amen. Thank you all.